Welcome to A League of Our Own, smart talk for women from the women of WRHU. We provide a forum for the issues important to women. I am Fran Spencer, and I am in the studio today with Juliana Spano. When you bump into the coffee table or twist your ankle stepping off a curb, you back up, express your discomfort, and get on with your life. You may have to deal with short-term pain. You may have to modify your activities for a short while, but eventually the pain and discomfort subside and you move on. But what if it doesn't? What if the pain doesn't go away? An estimated 1 in 5 Americans suffers from chronic pain that lasts at least 3 months and at most a lifetime. Think about that. Months, years, a lifetime of pain. And according to research, pain is a bigger problem for women than men. Women have more frequent episodes of pain. They experience greater pain intensity. Their pain episodes last longer, and they are more susceptible to conditions that can lead to chronic pain. Too many of us are at risk. We need to know more about this. Our guests today, Jim Broatch and Beth Seickel, are here to help educate us about chronic pain, specifically RSD and CRPS, both of which will be defined for you in a moment. Jim Broatch has served as the Executive Vice President of RSD Syndrome Association for the past 16 years. He holds a Master's of Social Work and has worked in the not-for-profit world for over 40 years. RSDA's mission is to provide support, education, and hope to everyone affected by CRPS and RSD and encourage research to develop better treatments and a cure. Beth Seickel is no stranger to us here at WRHU. She has brought her expertise to us several times. She is a registered nurse by profession, but what you need to know about Beth is that she's a leader and an activist. She has been awarded many times for her work with asthma and allergy. She has worked tirelessly on behalf of girls through the Girl Scouting community, and she is now immersed in the RSD community, to which she brings her leadership and activism. She is also a friend, and I have seen firsthand the toll that the chronic pain she experiences has had on her life. She has a very compelling and important story to tell us. Welcome, Beth and Jim. Thanks for joining us today.
Thanks, Fran.
Jim, we have all these initials. We've got to define our terms, okay? So RSD, CRP, CRPS, what are we talking about?
Even before I get into the names, I would like to just tee up a description of the disease.
Sure.
Given by a young adult. We asked her to look at a public service announcement, a possible one, and she wrote 2 things, and it's just amazing. Imagine the most excruciating pain you've experienced, and then experience that pain 24 hours, 7 days a week. Imagine your leg or arm or face looking like the site of a forest fire, a scorched crimson wasteland. Imagine sleeping under a tent because the pain of a sheet touching your body causes you to vomit. That's what life with CRPS, also known as RSD, is like. Another description. Imagine being unable to hold your husband's hand or touch your child's face. Imagine months without a kiss or hug. Imagine life with no touch at all because of severe pain. Complex regional pain syndrome, CRPS, causes excruciating pain. A single brush from a loved one feels like grabbing a hot pan without an oven mitt. It's uncontrollable, it's constant, 24 hours, 7 days a week. Over the years, reflex sympathetic dystrophy morphed into complex regional pain syndrome. It was first seen in the United States in returning soldiers. They came back from fighting for the Union, and they had this burning, stabbing pain. They wound up at a hospital in Philadelphia, and at that point, the only thing that gave them relief was shoving their hand in ice water or morphine.
Now, when was this?
This was right after the Civil War, so this was like 1866, 1867. The neurologist was Silas Weir Mitchell, and he was the father of American neurology, and he coined the term causalgia, which comes from the Greek burning pain. And then in the 40s, they changed the name again to reflex sympathetic dystrophy because they really thought that the mechanism underneath the disease was the sympathetic nervous system. In the 90s, they changed it again, called complex regional pain syndrome type 1 and type 2. The difference is in type 1, it seems like you cannot identify a particular nerve that's involved. Type 2, you could definitely see the nerve lesion. The treatments are similar for both. Maybe in the future when we have better imaging, there will be no differential because there definitely is, in both types, there's nerve damage.
Is all chronic pain under this umbrella, or this is a very specific type of chronic pain?
Complex regional pain syndrome is under the umbrella of neuropathic pain or nerve pain. We don't know exactly how many people have it. We suspect that each year 60,000 Americans develop it. The number one reason they develop it is some type of trauma. Fracture, sprain, crush injury, or it could be simple as a needle stick. We've heard people who have just in a parking lot shopping, just knocked into a car mirror. And for some reason, there is this incredible pain. There's this unbelievable inflammatory response. If you look at someone with CRPS, at least in the acute phase, they're sweating, they have swelling, and there's red, and sometimes it's blue. It's the most painful thing that could happen. There's a McGill pain index that rates pain, and CRPS is at 42, which is actually higher than an amputation of a digit or childbirth or cancer pain.
We've never known this. Until Beth, I never even heard about this. So a lot of people are going around miserable and nobody is telling them what's wrong.
I will say that too, because as a nurse for a gazillion years, I probably had patients that had this condition, but I didn't know. I really didn't know. And looking back now, it's a little humbling because now I'm in that position. And to think you make these assumptions when you see patients, because I'm just speaking of the medical community in large. In the 9 years I've had it, I've seen that my colleagues now are talking about it more. It doesn't mean they know as much as they should, but at least we're talking about it more. But before, we didn't. People would come in with these odd neuropathic pain, different kind of symptoms, and it was kind of blown off a little bit. I think as we get more able to share the information and Jim to come to the forefront and talk about it, I think the talking is really, the education is what's going to make a change, because there are probably a lot of people walking around post-surgeries or post-brain ankles and not knowing what's wrong, and you go to the doctor and sometimes they just look at you and say, well, I can't do anything for you. I don't know what's wrong with you.
Well, they tell you to get over it.
Yeah.
They don't understand that.
Especially as a woman.
Yeah, particularly if it's a woman. Mm-hmm. Well, that's a whole other issue, part of that. But that is important because they don't understand that pain would persevere as long as it does. So they're assuming that somehow you're prolonging it because of emotional issues, whatever it might be. All right, so you brought up something that I was going to mention later, but I want to mention it now. What is it? Doctors, nurses are never taught about this?
I went to nursing school almost 30 years ago, and pain was a very limited discussion, and it was really post-op pain or, cancer treatment pain. That was it. There was no other discussion on pain. The NIH, the National Institutes of Health, they don't spend a whole lot of funding on pain.
1 penny of any healthcare research dollars invested in pain research, that's 1%.
This is 1%.
And that's the general scope of pain. That's not just CRPS.
Right.
That's pain in general. And then it's allocated individually. So that's hardly any kind of funding going towards.
So obviously, if the practitioners are not being educated about it, when it comes to them, it's not going to seem important, which is something that I really have with the medical field that I get really irritated, because many times when you mention something, they'll say, well, there's no research to support that. Well, then start looking. It doesn't mean that whatever you're talking about is not true. It just means they haven't researched it. There's really been no kind of reports about it. And now I read, I think it was on your website, where it said it takes an average of 7 practitioners, somebody who's suffering, to go to 7 different people before somebody says, bingo, I know what that is.
I want to go back to medical school. We did a survey. We hired a consultant, and we went to 7 medical schools. And we asked them, 1, do you talk about complex regional pain syndrome, or do you talk about pain? And so there's 110 medical schools in America. Only 7 of them have hours in pain management. And that's about 7 hours at best. And if you go to veterinarian school, you have 50 hours.
Wow.
And so go back to the NIH, that there's all kinds of different institutes, but there's not an office of pain. There's not an institute of pain, but it's the number one reason we go to the doctor.
Absolutely.
Is pain.
Yeah, of course. Absolutely. You had seen something where it said 12% of those people who have had double hip replacements a year and a half later have near chronic pain. So therefore, surgeries are one of the implicating factors, right?
Definitely. I know for me personally, I developed it after I had an ACL repair on my knee. And when I woke up in the recovery room, I just remember waking up screaming in tremendous pain. I really couldn't express what it was, but I knew it wasn't post-op pain. It was unbelievable pain, almost like you're being amputated. And the pain medicine, all they do is knock you out. It really didn't help me, I'll be honest with you. And I think part of the issue, too, is you can't really physically see it. Again, as a health practitioner, we're trained to assess a patient. You can look for a broken bone. You can see bones coming out of skin. It makes sense. If you're in pain, I totally get that. But when you can't physically see it, it's hard for people to comprehend that.
Think about how they measure pain. They do it with smiley faces. Tremendous smile is 0, and someone with a tremendous frown is a 10. So they assess your pain. Where are you? Are you 1 through 10? Where are you? But it's a subjective measure. Mm-hmm. And as you said before, women have greater intensity. They have less tolerance to pain, and their pain has been minimized over the years. I'm reading a great book called A Nation in Pain by Judy Foreman. She's a former Boston Globe columnist. And she talked about gender. And she said one of the reasons we don't know more about why females feel more pain is just one simple fact. We do a lot of our research with rats, and over 75% of the rats are male. They're complete.
I could say a lot about that in male and rats, but anyhow.
Speaking about that, it was funny because I thought about this. There's a wonderful magazine, Pain Pathways magazine. Excellent, really, really excellent. It talks about all different kinds of pain, but I find that sometimes you can utilize from other organizations things that
Sure.
will help you too. And it talked about men and pain. It was just kind of comical. This came up. And I thought this is very true. I think the reasons, another part of that is that men tend to, no offense, Jim, I'm sure you're totally different than my husband, but men tend to really seek out help not as quickly as women. I think men have a harder time explaining what pain is. Pain is kind of a broad topic. That's not always what I feel. Sometimes what I feel is I'm just burning up. And I'm not sure that's really pain. I'm just sizzling like an egg. So I think part of it is that men don't really come to the forefront and say that they're having pain.
Could there be something having to do with how we are physically made up in terms of hormones that
Definitely.
contribute to the gender difference as to how we feel it?
For sure.
They talk about that young boys and girls up until puberty have the same pain intensity, and then there's a differential. So they're looking at female hormones and male hormones, and there's no smoking gun yet, but that seems to be an area rich to research.
All right, you started to tell us your story. You were having an ACL repair.
Mm-hmm.
And then this whole journey began. So tell us a little bit more about how somebody helped you to recognize what it is, how long it took, how many doctors you went through, and what have you learned from that?
Well, it's almost a 9-year story. It's hard to believe it's that long. It took close to 6 months after I had that surgery to finally find a neurosurgeon who said, you have CRPS. And, at the beginning, I was elated because I thought, great, now I know, because they were sending me for all these scans and tests and rule out clots. And I think that's important to do. You should rule things out so you don't miss things. But I knew from having these electrical currents going on in my leg, and it would get very shiny, almost like I did a wax. And I'd look at my leg going, what the heck is wrong with this leg? And then it would start to mottle and turn blue. And then my toenails got really, really hard, but the other foot was fine. So a lot of these bizarre things happen. In fact, one thing that came out, which I couldn't find until recently, was my skin turned like chicken skin. You ever see a raw chicken when you're going to cook it? And it's like goosebumps, but it's not. It was just on my affected leg. So I knew it was neuropathic, but I couldn't get anybody to really concur what this was until the neurosurgeon. He just, blurted, you have this. And I thought, great, what do we do? I was excited for a little bit until I really dove into the research of what this was to realize this wasn't really the diagnosis I truly wanted to hear, because there isn't a cure for it. It is treatable. It is manageable. It can go into remission. Everyone's a little different. Unfortunately, the longer you delay in having it diagnosed and assessed, the less likely that it's going to go into remission. So for me, it has spread from my left leg. It went linear right up to my abdomen. I started getting a lot of burning pain in my skin. And I kept thinking, is this me? And you take a shower and you turn to the shower. The left side would burn like knives are going into you. And then I go to the right side and it felt normal. And then you're still thinking, there's something wrong with me. Maybe I'm imagining this. But you realize that you're not. It now is on both of my extremities. It crossed over to my right leg. I have it in my left eye. I have it internally. I now have it in my GI system, which that's really a major issue. And I have it now in my nose and my tongue and my mouth. So it's a really bizarre condition to have. And I think at the beginning, I didn't know enough. This was before I really spoke to Jim, because he was really my savior for this. When I first got that diagnosis, I just kind of accepted what the neurosurgeon said, and he wanted me to have a nerve decompression surgery, which eventually I did. But I remember calling Jim almost 9 years ago, and he spent a good 40 minutes with me. I called him, and honestly, I didn't know this organization, because you can find anything on the internet. You don't know if it's really reputable.
Right, that's right.
But I did call and thought, here I am, a medical professional, and I really don't know. I was overwhelmed. I don't even know what to do for myself. I want to do the right thing, but I don't know what to do. And when you finally go to the doctor, they start flinging out all these prescriptions to you. You walk out with 6 or 7 prescriptions. This is not going to help me. So Jim spent a good 40 minutes with me, getting me started on this path of education, which is really why I really now want to give back to other people who are just lost and don't know where to turn.
All right, so Jim, you've been the executive vice president for 16 years. How and why did you get involved with this?
As you mentioned in the introduction, I've always been in not-for-profit management. I was serving on the board of the National Organization of Rare Disorders. Acronym is NORD. It's actually a Connecticut-based organization, too. RSDSA was started by 2 moms in Haddonfield, New Jersey in 1984, and they had worked tirelessly for 14 years in small organizations. When they're birthed, they're called kitchen table, because you're working right in the kitchen.
Sure.
And so they went for about 14 years, and they brought in a consultant. The consultant said, well, you're really going to have to bring in an executive to really go from your plateau that you're at to really try to do national expansion. And I was just lucky enough to be asked to interview for the job, and that was 16 years ago.
So did you have any idea of what it was?
No, I did not. RSDSA in the past had chapters, so I actually called some of the chapter leaders, and they helped me. But I just want to say one thing about this disease, that basically it's the only disease that starts with the word complex. And so what happens is that most doctors have probably seen one case or not. So you really have to find someone with a special interest. And then you really have to be your CEO or the quarterback of your team, because what happens too often, like what they did with Beth, they just go look it up.
Right.
Or they give you...
And they passed her on to somebody else and somebody else.
Exactly.
Right.
It used to be in the world of chronic pain, there were academic medical centers that had interdisciplinary teams. It didn't make money. So now you can count on one hand how many there are. When you're diagnosed with chronic pain, you have to find those practitioners that could help you. And too often we chased pain, get it back to zero. Now we're really saying, let's focus on restoring function. And also talk about, with this disease, it rips your life apart. So many marriages dissolve, jobs dissolve. This is if you don't get better. People lose their house. People are going to GoFundMe accounts to try to afford the medicine and the procedures, because a lot of times what is necessary is off-label. And it's harder and harder. You mentioned before the evidence-based medicine. If it hasn't been studied in this condition,
it's like it doesn't exist.
And it's not going to be paid for.
That's right. So that brings us to the Brad Jenkins Fund. Tell me a little bit about that, Beth.
One of the volunteer committees I work with on the RSDSA is the Brad Jenkins. He was a young man, and he was in a motorcycle accident, and he was severely injured and developed CRPS. And unfortunately, at a very young age, he had an accidental overdose and lost his life to CRPS. So his family, in his honor, because he wanted to really make a difference for other people who couldn't have a voice and didn't have a voice, to help them. So it's a grant, it's a small grant of funds, and we're always looking for donations. I didn't realize how much need there really was, because I have a great support around me. People that, are living in their car because they can't afford the rent. People that are trying to deal with this horrific pain, and they're out on disability because you cannot work. but they can't pay their electric bill, or they're single mothers with children at home and they're going to lose their apartment because they can't pay the rent. So there's an application that you can find on the RSDSA site, which is rsds.org. And you can fill out the application. We'll review it, and if it meets the requirements, then Jim calls and we give them a small grant.
All right, so now I know you a number of years, and I've seen some very difficult times, and times like now when you're on something else and you're able to function better. So how in general do people manage this? How do they find those different modalities?
Well, I'm going to say you need a good pain management team, and that doesn't mean a pain doctor. That's one of the measures, but you need a whole team. And it really sometimes it takes years before you find a team. You have to find maybe a neurologist that really understands CRPS. I have a wonderful interventional anesthesiologist that I found who actually saved my life because I was in the hospital like 17 times in like 6 years. It was just ridiculous. I've only been in the hospital now twice for a very short period of time for 2 years. I also found a holistic nurse through the board-certified nurse that works with Dr. Nello Lynn, who she and I co-chair a chronic pain support group at St. Francis. And then information's on the RSDSA site. I also have a whole conglomerate of people that help me manage it because you can't just do it from one aspect. So, for example, other things can happen to you when you have CRPS. So if you have like a appendicitis attack, and obviously it's not related to your CRPS, but you still need a plan when you have surgery. There's things that I need to have, like IV ketamine, etc., way before I have surgery to kind of calm down my central nervous system.
Jim, we said before that you've been associated with the RSD Syndrome Association for a long time, and hope is part of its mission. How do you provide hope for sufferers? Because ongoing pain is debilitating, depressing, until you find some way of managing it.
Well, first, how we provide it is by being there. We answer the phone. We get back to people within, if not hours, a day. I probably answer 40 to 50 emails a week. People want to tell their story. They might not have met anyone else in the world with this syndrome. Their doctor might have said to them, go look it up on the internet. Although 20% with this syndrome really have a chronic, a lot of people get better. So the first thing I try to elicit from them is, what have you tried? And a lot of times what Beth said in the beginning was she was given 9 prescriptions. So if you take 9 pills at once, what's working?
What's working and what are the side effects? Yes.
The first thing is to learn that if you don't use it, you lose it. What happens is that CRPS generally presents in a limb after some type of trauma. And what you immediately find, you have this horrific pain, but if I don't move it, I will feel better. And that's the worst thing that could happen, because that it can spread at that point, and also your joints could stiffen and your muscles could atrophy.
And physical therapy and occupational therapy is all very important as part of that team management. But I did find 9 years ago that there really wasn't knowledge even in the physical therapy world. I wound up downloading a lot of information from RSDSA to bring with me to the physical therapist. Like, for example, do not put ice on your limb with CRPS. And so as a health practitioner, when you have swelling, which sometimes you get, and mine now turns hot and red like a lava rock, you want to put ice on it, but it's counterproductive. So just to be able to bring something into your physical therapist and say, this is not just me, this is now what the medical records are showing, please don't use ice. I can't tell you how many times I talk to people and they said it was so much worse after they put ice on, but you don't know. How are you supposed to know that?
So that's a very specific and important tip that people need to know.
What I discovered, that it takes a long time for someone to accept that they have a life-changing condition. And then the second thing I really try to encourage them is to grieve the loss of their former life. My pastor always says life changes on a dime. And it does with this. You're talking about, you sprain an ankle, you fall, you step off a curb, and you have this horrific pain, and you're chasing the diagnosis. People are minimizing distress that you're in, and you're just looking for relief.
And because it's a neuroinflammatory condition, you need an anti-inflammatory. There's different categories of medication for neuropathic pain, anticonvulsants, because it helps calm down the nerve. From
the older antidepressants like Elavil,
yes.
amitriptyline, nortriptyline.
Right. or Savella. Savella came out specifically for neuropathic pain. It's considered an antidepressant, but it's really just used for neuropathic pain. Ketamine is a big medication. Before I have like a colonoscopy and a regular outpatient procedure, I have to have it in the hospital. Why? So I can get the extra IV ketamine so the trauma of the colonoscopy won't make my CRPS spread. There's IV ketamine infusions, which I really need, but it's a cost thing. The other part of living with this condition is that most of us lost our professional career. You know, I'll always say now I'm a nurse because I've kind of grieved, like Jim said, I've grieved the loss of what I was. I lost my private practice. I was a lecturer. I presented in front of the NIH. I've done lots of different things. That's not who I am anymore. But you know what? That's okay because we all evolve into something different. But I'm 9 years in. So I do understand when someone calls and they're just devastated because it is different. Your whole relationship changes. Sometimes just laying down next to my husband, the hairs from his arm, they're like a wool blanket. And I sit there going, okay, just be calm, just be calm. And then I'm like, go away, go away. I can't wear shoes. I can't wear socks. Can't even put the bed sheet on. It's so ridiculous.
That's important, Beth. I think we should just focus on that for a second. One of the cardinal symptoms, it's something called allodynia, where a mere non-noxious stimulus, whether it be a touch from a loved one, or it could be the wind, it could be a shower. Some people don't shower because of the water. And when we do our conferences, we do a number of conferences a year, even in the winter, sometimes people will, if they have it in the lower extremities, they'll come in shorts because they can't have clothing
something
touch
on them. From my perspective now looking, the good thing I feel is that having seen Beth in different stages and seeing that at this point there's some management techniques going on that are helping her, that would also be something to put out there, that as bad as you might feel, there is the hope we talked about.
Sure.
So tell us your contact information so anybody hearing this can get in touch with you.
We have a toll-free number. It is 877-662-7737. Our website is rsds.org. We have a small website, and we get over 27,000 hits a month.
Wow.
And that's just because people are searching for an answer for pain. It may not be CRPS, but we'll try to help anyone, direct them to the right resources.
I'd also like to add, too, because I was asked to be on the peer-to-peer communications conversation program. And Linda Lang, who's been very active in RSDSA, she started that. And so anyone that would like to speak to somebody else who's living with this condition or would like to volunteer for peer-to-peer, they can reach out to Linda Lang, Linda, L-I-N-D-A, Lang, L-A-N-G, at rsds.org. The other thing, too, we should put out that it's not just adults that get CRPS. It's also children and teenagers. In fact, in my support group, I have quite a few parents of teenagers who come, even though my group is not really for pediatrics, but I allow anyone to come in. I can't imagine being a teenager going through regular adolescence and having to deal with this. However, on the flip side, teens and children seem to, if they get the treatment quickly enough and they're diagnosed quickly enough, seem to rebound pretty quickly and it goes into remission.
We were really blessed this year. We did a camp for children in pain. We did it in Kentucky. It was the dream of someone on a board of directors, Sue Pinkham. First year, we had 19 children and their parents come to Kentucky. And it wasn't a medical camp. It was just a camp to get away. They played games. They fished. They rode horses. It was just fabulous. So this year, we put together some piggy banks, sent them out to 150 families who want to help send a child to camp because it's tuition free. The other thing just about children, as they're battling this disease, they miss more school than children with cancer. And that's how debilitating it can be.
Boy, this is really an eye-opener, this whole discussion. And Jim and Beth, thank you for coming today and educating us about RSD and CRPS. Prior to a few years ago, I'd never heard of it, and I'm willing to bet that there are many people in our audience who are just learning about it today, and that's the point.
Yes.
Speaking about it, its symptoms, who's at risk, how to deal with it, and most importantly, what you just did, providing contact information for resource people who can guide someone through it. It's going to help someone today, I know it. We should all be grateful that there are people like Jim Broatch and Beth Seickel who share their time, their knowledge, and their commitment so compassionately. Thank you again. Thank you to listening to A League of Our Own, Smart Talk for Women from the Women of WRHU. I am Fran Spencer. You're listening to WRHU, 88.7 FM, Radio Hofstra University, or on the web, at wrhu.org.